You lost 40 pounds. You felt better than you had in years. And then you stopped the medication. 3 months later, half of it was back. 6 months later, most of it. In clinical trials, most people regain 2/3 of their lost weight within a year of stopping. So is this drug just renting you a body? Here's the thing, the rebound is not random, and that means you can plan around it. Quick note, I'm a licensed physician, but I'm not your physician. This is not medical advice. Consult your doctor before making any decisions. All right, let's get into it. Let's start with the numbers, because the numbers are uncomfortable. In the Surmount 4 trial, one of the key Tirzepatide studies, people lost about 21% of their body weight during the 36-week lead-in. Then, those who stopped and switched to placebo regained on average about 14% of their body weight over the next year, which works out to roughly 2/3 of what they had lost. 2/3. Now, before you close this video, let me give you the full picture. First, most trials model a clean stop, no taper, no transition, and limited structured support after discontinuation. Second, the people in these trials didn't necessarily have structured diet or exercise support after stopping. Real-world outcomes with proper habits in place look different. Third, and this is important, some people did maintain a meaningful portion of their weight loss. It wasn't universal regain. And we see a similar pattern with semaglutide. In a major extension study, people regained about 2/3 of the lost weight within a year after stopping. So this isn't a Tirzepatide problem, it's a biology problem. But here's the honest truth. In these trials, most people who stopped without a plan regained significant weight. That's not a flaw in the drug, that's biology. So why does this happen? Because the drug wasn't removing the drivers, it was managing them. Here's what these medications actually do. They reduce appetite, they slow gastric emptying, they improve insulin sensitivity, they make food less interesting. But here's what they don't do. They don't rewire your hunger hormones permanently. They don't fix the environment that drove the weight gain in the first place. And your body also becomes more efficient. You burn fewer calories than you'd expect at the same weight, and hunger signals tend to rise after weight loss. When you stop the medication, the appetite suppression goes away. And for many people, hunger often comes back stronger than you expect. There's a hormone called ghrelin, your body's hunger signal. When you lose weight rapidly, ghrelin tends to increase. Your body is essentially screaming, "We lost too much, eat more." This is called metabolic adaptation, and it's not willpower, it's physiology. On top of that, if you lost muscle during the weight loss phase, your resting metabolism is now lower than before you started. Less muscle means fewer calories burned at rest, so you're hungrier and burning less. That's the rebound trap. But here's the part most people don't hear. The rebound isn't inevitable, it's predictable, and predictable means preventable, if you know when to act. There's a concept in obesity medicine called the behavioral window. It's the period while you're on the medication, when appetite is suppressed, food noise is quiet, and you actually have the mental bandwidth to build habits. That window is the most important period of your entire treatment. Because the drug buys you time, what you do with that time determines everything. Here's what the data and clinical experience suggest you should be doing during that window. Number 1, build the protein habit. Research suggests adequate protein intake helps preserve muscle during weight loss and supports satiety, even after the drug is gone. Aim for enough protein at every meal, not just sometimes, every meal. Number 2, start resistance training, not cardio. Resistance training. Muscle is metabolically active tissue. More muscle means higher resting metabolism, which is your best defense against rebound. 2 to 3 sessions per week is enough. You don't need to become an athlete. Number 3, practice eating without the drug's help. This sounds strange, but bear with me. On the medication, eating less feels easy. Off the medication, it doesn't. Use the suppressed appetite phase to practice portion control, mindful eating, and recognizing real hunger versus habit hunger. Because when the drug is gone, those skills need to already be automatic. Number 4. Don't stop abruptly without a plan. In real-world practice, many clinicians prefer a structured transition plan rather than stopping cold, because it can make follow-through, monitoring, and habit maintenance much easier. Talk to your doctor before stopping. This is not a decision to make alone. Now, what if you already stopped? What if the rebound already started? First, don't panic, and don't shame spiral. Weight regain after stopping incretin-based medications is not a personal failure. It is a documented physiological response that happens to many people who stop without support. Here's what to do. Option 1. Talk to your doctor about restarting. For many patients, these medications are intended as long-term therapy, not a short course. The research increasingly supports that obesity is a chronic condition, and treating it chronically may be appropriate for many people. Option 2. If restarting isn't possible, refocus on the fundamentals: protein, resistance training, sleep, stress management. These aren't consolation prizes. They are the actual mechanisms that drive metabolic health, with or without medication. Option 3. Be realistic about the timeline. Rebuilding after rebound takes time. Research suggests that metabolic adaptation can persist for months after weight loss stops. Patience isn't optional, it's part of the biology. And one more thing, be careful about the shame narrative around rebound. You just didn't try hard enough is not what the science says. The science says these drugs work powerfully while you're on them, and the body fights back when they're gone. Knowing that in advance and planning for it is the difference between a successful long-term outcome and a frustrating cycle. So let's bring this together. Here's the framework I'd want every patient on these medications to hear from day one. These drugs are tools, powerful tools, but tools with an expiration date, unless the habits are built while the tool is working. The people who maintain their weight loss long-term aren't the ones who were on the highest dose. They're the ones who used the quiet period, when appetite was suppressed, to build the habits that work without the drug. Protein at every meal, resistance training 2 to 3 times a week, a consistent sleep schedule, a transition plan before stopping. That's it. That's the framework. It's not complicated, but it requires starting before you think you need to, because by the time the rebound starts, the window has already closed. So here's the honest summary. Rebound weight gain after stopping these medications is real, common, and biological, not a character flaw. The data shows most people regain significant weight without a plan. In practice, habits built during treatment are what most often separate long-term maintenance from rebound. The drug buys you time. What you do with that time, that's what determines the ending. This is not medical advice. Consult your doctor. Now you know why rebound happens, and exactly when to act to stop it. If this helped, hit subscribe. Next video is coming soon.